Hi students, I'm Dr. Sonal Parihar. I'm your OBGY faculty in Manipal Medics. So today we are here to discuss the questions in NEET PG 2024, which you just recently gave, and both the sessions, the morning as well as the afternoon session. What I can see from the different discussions that you're having in different groups, Telegram, and you are discussing on WhatsApp groups, you found the paper quite difficult. Now, because there was a lot of integration, OBG had literally swiped away all the subjects. So we were like almost 50-52 questions from OBG, but I'm not covering all of them because some of them are linked with pathology, some with radiology, some by FMT, forensic medicine. So I have given those particular questions to the faculty, the concerned faculty. But I would say that the questions were not that difficult. They were not that difficult because they are, first of all, they are all simple questions which you must have read. I, as a faculty of Manipal Medis, have covered all this in my lectures, directly or indirectly, and the MCQs and the crash course that we have done. There was just one question which was probably not directly covered by me in the app, but that will be covered very soon in the INSET Prepathon. So overall, the paper was not that difficult, but yes, lot of integration, lot of radiology images. So our radiology faculty was thinking how many questions he's going to take, but it was actually linked with surgery, OBGY, medicine. So it was like more of integration. And if you see the STEM, they were not that difficult. And if you look at the options, sometimes the STEM may be something like, oh God, it can be anything. But when you look at the options, then you can easily select, okay, this, these three do not fit into the STEM. So definitely this fourth one is the answer. So yeah, I do agree that it is kind of time consuming when you have a time limit. You have to do 200 questions in a short time and so many subjects and trying to remember so much. But overall, the paper was not that difficult, but now it's over. So let's not think. You have already discussed it with your friends. You must have seen the other faculties discussing. You must have gone through the books. So let us quickly see the questions and see how to approach to these questions and just quickly revise some theory attached to it. There may be some errors because I've got these questions from different groups and different students. So there may be some errors which you might think that, okay, this was not the question, but at least I'll give you the gist. Okay. So patient of CA cervix comes to you, very straightforward question. What will be the stage if the pelvic wall is involved and there is hydronephrosis? Very, very simple question, children. You know that stage A, that is 1A and 1B. What is that? This is a microscopic one, right? This is microscopic and this is clinical. Stage 1 means it is limited to the cervix. Okay. Now, let's quickly do the staging. Stage 0 is carcinoma in situ or CIN3. Stage 1 will be strictly confined to the cervix. A, we are not going to the details. A1, A2, you know that. A is microscopic. B is clinically visible. It is less than 2, 2 to 4 and more than 4. We know we don't operate after it is more than 4 centimeter. So we operate only up till 1B2. Then coming to stage 2, 2 means it is either going towards a parametrium or it is going below in the vagina, but not in the below the upper two-thirds. So it is the upper two-third vagina or the parametrium. So first we come to 2A and then 2B. 2A means upper two-third of the vagina and 2B means parametrial involvement. So remember, if this is the cervix and this is the pelvic wall, in stage 2, we are midway somewhere here. We have not reached the wall. Okay. So the cancer is either spreading downwards towards the vagina, two-third of the vagina, or it is going sideways to the parametrium, but not up to the pelvic wall. So this is A and this is B, right? This is 2B and this is 2A. Simple. So it is very, very simple that hydronephrosis, what they've asked in the question, is basically stage 3 because it is now going towards the pelvic wall. So what happens when it goes towards the pelvic wall? There is a ureter running here. The ureter is entrapped by the cancerous tissue and that leads to hydronephrosis because it leads to entrapment. The urine stops, the hydroureter develops and back pressure, hydronephrosis. So simply hydronephrosis develops in stage 3B, not 3A. Okay. So it is V and P. First, it will go down in the vagina and then it will go towards the parametrium. So stage 2, V is two-third, upper two-third and P is half of the parametrium or at least not till the pelvic wall. Then stage 3, V is the lower one-third of the vagina and P is up till the pelvic wall. Once it reaches the pelvic wall, means it has entrapped the ureter. So it is simply 3B and that is the answer. Okay, very, very simple, straightforward question. I find CA cervix staging to be very simple. अब लग रहा होगा मैडम क्या बोल रही है, but actually it is very simple. It is simply VP. And then once it comes to 4, it is distant metastasis and local metastasis. So local is A and distant is B. So VP, if you just follow, and then stage 1 is A and B. So microscopic, macroscopic. Again, you just have to remember the numbers. Less than 2 to 4 and 4, more than 4 centimeter, that is B. And in A, there is microscopic stromal involvement. So not that difficult. Okay. So very, very simple question. Let's move forward. Then, a victim of sexual assault is 22 weeks pregnant, which is correct. Now, this will be partly taken by Dr. Aditya also in FMT, but I'm going to just quickly tell you the answer. You know that. Okay. So MTP can be done after 20 weeks. There may be a different option, but this is what I could gather from the students, that okay, this was one of the options. It may be that MTP can be done up till 24 weeks. That is also correct if that was the option. So this is wrong because MTP cannot be done. This is wrong. It can be done easily, but after 20 weeks also. MTP can be done after 20 weeks only for danger to maternal life. No, I will tell you the latest recommendations and opinion of one doctor. No, we need two doctors here. After 20 weeks, we need two doctors. So the initial guidelines which were given in 1971 said that if the period of pregnancy is below 12 weeks, then it can be terminated by a single doctor. Between 12 to 20, we needed two doctors. Once the opinion is formed, the termination can be done by only one doctor, but the signature of two doctors is required. Termination was permitted only up to 20 weeks. Now, the latest recommendations say that in 2022, they said that a minor female, if she's pregnant or if she's mentally unstable or if she's had a rape, for example, this case, or there was an incest, very much like rape, fetal anomalies detected between 20 to 24 weeks, in that case, you can terminate pregnancy up to 24. After 24, you need a writ petition from the court. That was also, I think, a question, but that will be covered in FMT. Now, two doctors' opinions is very, very important after 20 weeks. So now they have changed it from 12 to 20. Initially, after 12, they wanted two doctors. Now, after 20, they need two doctors' signature. Okay. Now, another change. What are the other latest amendments in 2022? In an emergency, if there is an emergency, if you get a question like this, pregnancy can be terminated. They can break all the rules. For example, it can be done by a single doctor at any gestation, even without required training. The PG criteria and the number of MTPs criteria, it is not there. Even after 20 weeks, without consulting a second doctor in a private hospital, which is not even recognized or registered for MTP. So these are all the latest amendments given in 2022, just to make life easier for the patients. Now, third question. 35-year-old patient gives history of dysmenorrhea, infertility, and dyspareunia. So that is a triad, children. You know that. Dysmenorrhea, dyspareunia means painful sex, and infertility. That is a triad of endometriosis. Her laparoscopy picture is as below. There may be a different question, some different stem, but this is what I could gather from you all. So now, what you can see here, why do you get confused in the pictures when you actually see a cuvular uterus, when you see a ovarian torsion? You should know what they are trying to show you. What will ovarian torsion look like? Ovarian torsion will always look like this. Look at this. This is a torsion of the ligament. Okay. And the rest of the ovary will become dark. It will become dark black because it is a gangrenous ovary. Imagine the ovary undergoing torsion. The entire ligament is undergoing torsion. So the blood vessels, the blood supply is cut off. So that particular organ will become black. So that is why the blackish shadow. But you will see a twisted thing, and that will be diagnostic. Okay. In chocolate cyst, they will show you the chocolatey material coming out. The chocolatey dark Cadbury like chocolate coming out. And why is it chocolate cyst? Because it is filled up with all the collected menstrual blood, because the patient is bleeding inside that endometriotic tissue whenever she has menses. Okay, so that is a chocolate tissue. Ovary has a lot of space, so it becomes filled with that chocolatey material. The other areas where endometriosis happens, they do not get filled up. They just get puckered, they get fibrotic, they get like red flame like appearance, all those puckered appearances. Okay, red degeneration of the fibroid will look something like this. So they will show you a fibroid which is kind of meaty look. It's like a meaty look. It is not a chocolatey tarry material. And this is a cuvular uterus. Look at the size of this uterus and look at the ovary. So in the cuvular uterus, they will not show you any material coming out. In chocolate cyst, they will actually show you material, chocolatey material dripping out. So that is chocolate cyst. Okay, let's quickly revise endometriosis profile, patient profile. The patient will be in their reproductive age group 30 to 45. 15 to 30% infertile patients will have endometriosis. They may be nullipara or they may be multipara also. 25% are actually asymptomatic. Symptoms are directly related to the depth rather than the spread of the disease. So it doesn't matter whether endometriosis has spread to the uterosacrals, it has gone to the ureters, wherever it has gone, it just depends upon the depth of that particular tissue, where it is going. Okay. Now, what are the clinical features? Dysmenorrhea, menorrhagia, infertility, dyspareunia. So this is a triad. So basically you got these three in your question. And this is definitely pointing towards endometriosis. Chronic pelvic pain and low back pain may also be the presenting feature. Clinical features depending upon where the endometriosis is actually attacking. So urinary frequency, if it is involving the bladder, dysuria, hematuria. Dyspareunia happens because of the pouch of Douglas, the implantation of endometriotic tissue into the pouch of Douglas, especially on the uterosacrals. So during sexual activity, that particular uterosacral, it gets hit, and definitely there is dyspareunia. Sigmoid colon and rectum, if they involved, there will be dyschezia. Then chronic fatigue, hemoptysis and chest pain if the endometriotic tissue is coming somewhere else in the lungs, and surgical scar. There was another question I know. After normal delivery, she came with episiotomy scar, which was painful and especially swollen up. That we will come to that question. So that was a scar endometriosis. Now, next question. Patient comes to you with secondary amenorrhea. She was given estrogen plus progesterone challenge, but still she did not menstruate. Looking at the image, identify the question. Now, I don't know, identify the condition. I don't know what image they showed you, but what I could gather, there was some image of a laparoscopic picture where there were a lot of whitish tissue instead of the red puckered or the blackish puckered look of the endometriosis. So that is the reason why I am showing you these pictures. I took these from Google because this is what I could gather from the groups the discussion was happening. So tuberculosis of abdomen looks like this is tuberculosis of abdomen. If they had shown you these white tubercles, can you see these white tubercles? This is all studded with tubercles, this all whitish tissue. So this is tuberculosis of abdomen, and the symptoms match with that. Because genital tuberculosis can attack uterus, and the second part of uterus which gets affected with tuberculosis is endometrium. So the first organ to get attacked will be the tube, and the second will be the endometrium. So tuberculosis of abdomen, I would go for this if this was the picture and this was the kind of stem given to you. Endometriosis, you know how it looks like, red flamy appearance or the black powder type of appearance, or the fibrotic tissue, or sometimes even the peritoneal, you can say the peritoneal defects, when the puckering, it just pulls the peritoneum inside. So these are all the features for endometriosis. Sarcoidosis was also an option, but it doesn't match with the pictures. So it is tuberculosis. Now, secondary amenorrhea, let us just quickly discuss when we give progesterone challenge and what happens if it is negative. What happens after estrogen and progesterone challenge? Now, what is secondary amenorrhea? Quickly. Absence of menstruation for 3 normal cycles in a patient who has had regular cycles previously. So consistently for 90 days, she is not bleeding. Or if a patient is having irregular cycles, then if she is not menstruating for the last 6 months continuously, that is secondary amenorrhea. Less than 9 cycles is in a year is also defined as secondary amenorrhea. These are the 3 definitions of secondary amenorrhea. What are the causes? Systemic diseases, any kind of disease like tuberculosis, chronic hypertension, chronic diabetes, renal disease, any systemic disease. Endocrinopathies, HPO axis disturbance, yes, definitely. That is why we have that table to evaluate the primary and the secondary amenorrheas. Gynetresias means there is some problem within the outflow tract. Either they are stuck up or there is some outflow obstruction. Nutritional factors, anorexia nervosa is a very good example. Drug usage, certain drugs like hypnotic drugs, antidepressants, they can lead to amenorrhea, psychological factors, and other rare causes. Now, first of all, we give them positive progesterone challenge. Let us just quickly revise this chart rather than going to the details. Now, so first of all, you have to exclude pregnancy. Right? So if they had asked you what would be the first approach, then you would actually go for an ultrasound. You will see what is happening in the ultrasound. What is there inside? Okay. So exclude pregnancy first of all. Estimate the serum thyroid, prolactin and estrogen levels because hormones are very important. Check sella turcica. You can do an MRI or X-ray of the brain, generally MRI or CT scan, so that you can check for the pituitary adenomas. Assuming that everything is normal. Assuming she's not pregnant, thyroid profile, prolactin, everything is normal, and sella turcica is also fine. Then you go with the progesterone challenge test. That is a progesterone challenge test. If anything was abnormal, then you have to treat accordingly. Okay. Now, if the progesterone challenge test is positive, means what? Means you have given external progesterone and the endometrium is responsive to that. That means the estrogen is enough in the body to prime the endometrium for the progesterone. You know that estrogen is responsible for producing the receptors for progesterone in endometrium. So if you give progesterone and she bleeds, that means there's a deficiency of progesterone. And when does that happen? That happens when she is not ovulating. If she is not ovulating, estrogen will go up and up and the progesterone will not get secreted because it comes from in the luteal phase. Okay. In that case, PCOS may be a possibility. So in that case, you have to do FSH and LH and check whether the ratio is abnormal, why she's not having good progesterone inside the body. In case PCT is negative, then you go for estrogen and progesterone challenge. This is what they've given you in the question. If this is positive, means there is a deficiency of estrogen. There is no problem with the endometrium. Estrogen is deficient. That is the reason why she's not menstruating. As soon as you gave her estrogen and progesterone challenge, she menstruated. So low estrogen will be, you have to check the FSH. You have to check whether she's going into premature ovarian failure. You have to check her karyotype. Maybe she's having a chromosomal problem that is leading to premature ovarian failure. Then if LH is normal or is low, if there is a Hypothalamic problem or a pituitary problem means both the sex hormones, the ovarian hormones are low. Estrogen, progesterone are low. So that means there may be a problem in the brain from the hypothalamus and pituitary. How do you distinguish between the hypothalamus and pituitary problems? You give a GNRH challenge. Okay, we know that. Now, in case it is negative, means the endometrium is either destroyed, it is absolutely gone, or there are synechiae inside. The most common cause of secondary amenorrhea is Asherman syndrome. When there is a lot of adhesions inside, you go inside with a hysteroscope, you cut the adhesions, give an estrogen, progesterone, put a copper T inside to it so that the walls do not stick together. Okay, so that may be a cause. But in this case, they have given you tuberculosis and sarcoidosis and endometriosis. So endometriosis will never present with secondary amenorrhea. Why will it present with secondary amenorrhea? It has to be a disease of the endometrium, especially when E plus P challenge is negative. Okay, so non-responsive endometrium, you have to go for checking like hysteroscopy, and you have to do a DHL, that is diagnostic hysterolaparoscopy. So this is the approach towards secondary amenorrhea. So I'm just skipping these slides because it's just the same thing. Okay, now next question. Flexion point in the Ventouse cup. Flexion point in the Ventouse cup is 3 cm in front of posterior fontanelle, 6 cm in front of posterior fontanelle, 3 cm behind anterior fontanelle, midpoint between both the fontanelles. Now, if this is the anterior fontanelle and this is the posterior, you know where the flexion point is. Now you must be knowing. If you have forgotten, you must have checked in your books. It is 3 cm in front of the posterior fontanelle. The entire length here is 9 cm. So the other correct answer will be 6 cm behind the anterior fontanelle. So this should be behind anterior fontanelle, not 3 cm, 6 cm behind anterior fontanelle. So this is the right answer, 3 cm in front of the posterior fontanelle. Okay, so that is a flexion point. That is why our Ventouse cups, the radius of this Ventouse cup is 3 cm. So if you put when we are actually doing a PV, it is very difficult. How will you measure? The patient is pushing and the baby's head is popping out. It's just there at the pelvis and then just at the perineum, and you're trying to put the Ventouse cup. So what do we do as obstetricians? We will just pass our finger posteriorly with the Ventouse cup and we feel the fontanelle and we try to fix the Ventouse, the small Ventouse, just there at the fontanelle, because we know that if suppose this is the fontanelle and my fingers can go till the fontanelle, I fix my Ventouse here. So the radius of this Ventouse is actually 3 cm. This is what the people have done, the manufacturers have done, because this is the easiest way. So if you put it at the anterior posterior fontanelle, here the rim of the Ventouse, automatically the Ventouse is at the flexion point. So this is how they have created these Ventouse cups, especially the kiwi cups. In my instrument class, in my INSAT prepathon, I will show you the kiwi cup. Okay, so this is how we actually do the Ventouse delivery. Okay, now patient of 14 years old presents with primary amenorrhea. She has normal breast development, axillary pubic hair are present. So first of all, if you just read this much, what strikes you? MRKH syndrome. In MRKH, there is no chromosomal problem. There is a problem with the Mullerian duct. The development of the Mullerian duct got arrested because of some mutation inside. So till now, you will think of MRKH, the Mullerian Rokitansky-Kuster-Hauser syndrome. Now they have shown you a picture of imperforate hymen, which is very, very simple. I'm sure they must have shown you this picture. This is a very, you can say, very prevalent, a very famous picture of imperforate hymen. So we know that imperforate hymen is a kind of gynatresia because it is a kind of obstructive primary amenorrhea. So that is 46XX. 46XY will be AIS. This will be Turner's, and this will be Klinefelter's. Okay. So this patient will not present with primary amenorrhea. Klinefelter syndrome, they do not look like females. They will be raised like a male only. Now, patient has a face to pubes delivery. What is the most likely type of pelvis she has? Now, there was a dictum whether they showed an image or they actually gave you the names of these pelvises. So I will be showing you these images also. I don't know whether in your question they had actually just given you the images. Then you should be very careful if they've only given you the images. So gynecoid is very much like a circle. Can you see this circle? Anthropoid is like ape-like. Okay, so this ape-like, this is like a monkey's face, ape face. Android is more, this is more projecting. So the ischial spine is more projecting, and even this heart shape, it's more of a heart shape. Android is like this. Ape shape, anthropoid will be like this. So there is a difference. Can you see? I'm just drawing it. Gynecoid is round and platyploid is like a bowl. Okay, these are the rarest ones. So if they've given you the picture without naming the pelvis, then you should be able to distinguish, okay, which pelvis is what. So Colburn and Mohoy classification, they gave the classification gynecoid, 50% of the females will have it. And this is transversely oval, commonest and normal female type. So this is like a circle. Anthropoid is ape-like. Anteroposteriorly, it is more it is having a big diameter, anterior-posterior much bigger than the transverse diameter. So AP is more than the transverse. Here AP is very less, so transverse is more than AP in the android one. Here it's almost equal, and here you can see the transverse diameter is much more than AP. So these are the differences. Okay, anthropoid, ape-like. Android is normal male type. It is heart-shaped. Only 20% cases. They may ask you the percentage also. So that's 50, 25, 20, and 5. Platyploid is flat bowl-like, least common. So you can see how flat it is. So just imagine the baby's skull coming in the platyploid, which has only this much AP diameter. So very small. So what will happen to the baby's skull? It will get crushed. So this bone, the sagittal bones will just overlap each other. So it will be a kind of asynclitism, posterior or anterior asynclitism. So the entire diameter of the skull will also change. Okay, you know that. So I'm not going to the details. So in this case, face to pubes delivery is possible. First of all, OP positions are more prevalent in these two kind of cases, the anthropoid and the android. In android, it gets stuck. It becomes a deep transverse arrest, or it becomes a persistent OP position. There is no place for the baby's skull to move. There is no way that it can move forward. So even if it moves slightly, maybe just 1/4 of the circle, and then it gets stuck, or it just becomes a persistent OP position. In anthropoid, because the AP diameter is quite big, so it does have a chance of rotating. It's a favorable rotation, or sometimes even simply a face to pubes delivery. You know, in a face to pubes delivery, the presenting diameter of the fetus is much more than the proper flexcephalic position. So anthropoid pelvis are the ones in which face to pubes delivery or a favorable rotation of the OP position can happen. So the answer is anthropoid. And let us just quickly read these facts. So commonest is gynecoid, wide, transversely narrow AP. Initially, I said it's like a circle, but yes, if you actually measure, then the transverse diameter will be more than the AP one. Normal female type is gynecoid. Male type normal is android, which is heart-shaped. Least common is platyploid. It is a broad, flat pelvis platyploid. That is the reason why there will be a lot of asynclitism. Transverse diameter is much more than AP, and the only pelvis where AP diameter is more than transverse is the anthropoid, which is the answer in this question. Face to pubes delivery common in anthropoid. Direct OP also common in anthropoid. So these two things are common in anthropoid. In android, persistent OP. So if at all the baby comes in OP in the anthropoid and android, it is the android which is going to get stuck. Persistent OP, DTA, because it rotates 1/4, or non-rotation or dystocia. It will lead to a dystocia. That is happening in android. Engagement by exaggerated posterior asynclitism. Now, what is posterior asynclitism? When the anterior parietal bone is presenting at the os, at the cervical os. So basically, exaggerated posterior asynclitism occurring in the platyploid pelvis, super subparietal. So basically, this is the biparietal diameter of the fetal skull. So if there is asynclitism, it will be either like this or like this. So super subparietal diameter of the fetal skull is basically engaging in the platyploid pelvis because of the asynclitism. I hope I am clear. Then coming to the next question. Now, grading of this pelvic organ prolapse. So I got these options from you all, and I don't know what kind of image you got, but I heard from the students, they told me, ma'am, we could see a uterus coming out from the vagina. So definitely it was 3rd degree. And some of them said there was a cystocele also. So I've taken this picture, and hopefully you can understand what is a cystocele. It is a bladder wall which is coming out, and anything coming out of the vaginal os, the introitus, is grade 3. Okay, so that is grade 3 with cystorectocele, or grade 2 with cystorectocele. I don't know what they showed you, but I will just tell you the theory. Okay, so this is the grade 0, 1, 2, 3, 4. 4 is precedentia, which is kind of same as 3, but if the entire fundus of the uterus is also felt outside, sometimes we do get cases. I don't have a real picture for you, but if I get it in the clinic soon, then I will take a picture and send it to you all. I will put it in the session. So basically, it is when you see this much cervix and some part of the body of the uterus hanging out, that is 3rd degree. But if you see the entire, like this much big mass, and you do a PV and you can feel the fundus also outside the introitus, that is a grade 4. So grade 1 is when the os has come below the level of the ischial spine. We know external os is at the level of the ischial spine. So slightly below is grade 1. Then at the level of the introitus is grade 2, and when it comes out of the introitus is grade 3, and then grade 4, the entire fundus is out. This is cystocele when the bladder wall is also coming out, and the rectocele when the posterior wall of the vagina is also prolapsing. So anterior wall of the vagina is bladder, and posterior vaginal wall coming out with the uterus is rectocele. Okay. Then patient had atonic PPH. Okay. She also has bronchial asthma. Very simple question. Which drug has to be avoided? We know it is PGF2 alpha. PGF2 alpha which is nothing but carboprost. It is not carbitocin. Carbitocin is an analog of oxytocin, which is very commonly used now, slightly costly, but it is much more potent than oxytocin. Okay, carboprost is an analog of, it is a kind of prostaglandin, just like misoprostol, just like danoprostone. Misoprostol is PGE1, danoprostone is PGE2, and carboprost is the strongest one. It is PGF2 alpha. So misoprost is PGE1 and oxytocin methergine, you know. Methergine is ergometry. Okay. Now, who remembers this table? You have to mug up this table. I'm sure you must have done it. So don't get confused and don't get scared. What is this table? You know everything. Oxytocin, it has to be given. It cannot be given bolus. It can lead to hypotension. Never give oxytocin IV bolus. 10 to 20 units in 500 ml. So 10 to 20 units means 2 ampules or 4 ampules or even 8 ampules sometimes in pph. 1 ampule is 1 ml, 5 units. Okay, 1 ampule is 5 units. So 40 to 60 drops per minute. It is given as an infusion. Carbitocin is an analog of oxytocin, costlier, more effective, and the dose is 100 microgram IV. It can be given IV bolus. Okay. Now, ergometrine, methyl ergometrine is what they have given you as methergine. That is a trade name, very famous trade name. So it is 0.25 milligram IM or IV, 0.2 milligram IM or IV for methyl ergometrine. So ergometrine is 0.25, methyl ergometrine is 0.2, slightly lower dose. It can be repeated every 15 minutes. Sorry, it is not replaced, it is repeated. Okay. So this can be repeated every 15 minutes, but generally we don't repeat that much. It can lead to hypertension. Now, carboprost is PGF2 alpha. 250 microgram is same as 0.25 milligrams, right? 0.25 milligram. And if you give maximum 8 doses, if you multiply with 8, what will it become? It will become 2 milligram. Okay. So 2 milligram is a maximum dose. So that is a maximum dose that can be asked, and very commonly asked MCQ question. What is the maximum dose of carboprost that can be given? So 8 doses of 1 ampule, which is 250 microgram, which is equal to 0.25 milligram, multiplied by 8 becomes 2000 micrograms. That means 2 milligrams is the maximum dose. And it has to be given either intramuscularly or directly into the myometrium of the uterus. Now, it is contraindicated in asthmatic patients because it can lead to bronchospasm. It is also contraindicated with risk of amniotic fluid embolism because it is the strongest and most potent prostaglandin which causes contraction of the smooth muscles. It may lead to diarrhea. Any prostaglandin that we use, whether it's misoprostol, whether it's carboprost, they all can lead to diarrhea, hypertension, vomiting, fever, tachycardia, and pyrexia. Hypertension generally with carboprost, not with misoprostol. Relatively contraindicated in renal, liver, and cardiac diseases. Misoprostol is not as potent as carboprost. It can lead to hyperpyrexia, diarrhea. Whenever we use this for second trimester medical abortions, then yes, patient does present with tachycardia, fever, diarrhea, that is, and vomiting. That's common. It can be safely given in asthmatics. It does not act on the bronchioles. Now, the dose is 800 micrograms sublingually. You have read this even in the abortion cases, we use the same dose. Dinoprostone is generally used for induction of labor. It can be given as a per rectal drug, high dose 20 milligram to stop PPH, or even per vaginal every 2 hours. And tranexamic acid is antifibrinolytic, so 500 milligram IV IM can be repeated 3 times a day. It is recommended if all the above drugs fail. Okay. Again, dinoprostone can also cause diarrhea. As I told you, all prostaglandins can cause GI upset. Now, identify the condition for which this type of grading is used. Now, this is a difficult question, I would say. We don't teach you POPQ staging because it is not required. POPQ staging was not famous even when I was doing PG. That was long back. Even after that, even if you ask the present residents, they don't use it. In the previous staging, we used to tell you that you have to use the introitus, that is a vagina, as the reference because we see where the cervix is, whether it is above the introitus or it is outside the introitus. So that is second degree, third degree. But now in POPQ, we are using hymen as the reference. That is all. But this particular grading, we don't tell you. So if remember, if you get this kind of AABBCC means it is kind of a POPQ grading. A here, the small a stands for anterior wall. The small p stands for the posterior wall. This is all you need to know. Okay. So this is definitely pelvic organ prolapse, the POPQ staging. The POPQ staging. Definitely very, very confusing. But if you actually look at the options, you can just negatively mark CA service. We don't use this staging. Endometriosis, no, not at all. AFS scoring is done. So basically, we know that we don't have any of these kind of stagings for or classifications for CS cervix, endometriosis. We use AFS grading for endometriosis. So once we actually see that, okay, we just negatively mark, oh, this can be the answer, this can't be the answer, then we can come to pelvic organ prolapse, because we know there is a staging which we haven't read, that is POP2. Okay, that is how I can explain, because even for me it is very, very difficult. So POP2 staging, you can see AA, PP, BB, BP. This is all they are saying. So 0 is when the leading edge is less than minus 1 centimeter, means hymen is the reference. So less than minus 1, plus 1, then plus 2. So you don't actually have to mug up this. This is just AA for the anterior wall and AP for the posterior wall. Similarly, BB and BA and BP. Okay, so this is the POP2 staging. This is all I can tell you. Okay, you don't need to go through that. Just remember hymen, and whenever there's A, that is anterior, and P is posterior wall. Then, what is the earliest time to insert IUCD post-delivery? Children, if you have gone through the Manipal Medes app, we have actually covered everything very nicely. The theory, the crash course, the MCQs which we have made as faculty. We have made these MCQs, and then we are making some comedy reels for you, in which in that comedy, while acting, we are acting as a patient and a doctor, or yes, as a paramedic, we are actually telling you the theory. So we are telling you the tips, some particular topic we are picking up, so that it becomes easy for you to understand the high yield topics. And I'm proud to say that one or two of those questions have actually come in your proper NEET PG 2024 exam, the proper language that we have used. Okay, the proper one-liners that we have used. So go through that. And this particular question is definitely from the theory that I've covered, although it is not a very high yield question, but even then I covered this in the IUCD chapter, the PP IUCD, because it is recommended by Government of India now to control population. So yes, you have to go through the Manipal Medes app. You will come to know that it is very simple question, and that is within 48 hours. Let us quickly see how we insert PP IUCD. What are the timings? Now, post-placental, if you do it within 10 minutes, that is known as post-placental insertion. Postpartum will be after 10 minutes of placental expulsion till 48 hours of delivery. So within 48 hours, if we do, that is the earliest one. They have not given you 10 minutes. So you have to click on, you have to tick mark 48 hours. Then post-abortal. When we do an MTP, we can do it, especially when we're doing a surgical termination of pregnancy, we can do it immediately after TOP or after spontaneous miscarriage. The patient has come to you. Or if she doesn't want to get an IUCD at that time, immediately after abortion, then you can do it in the interval period, that is on the day 5 of the menstrual cycle. Even during menses, within first 10 days of the menstrual cycle. So why did I write 5th day of the menstrual cycle? Because this is what I prefer. But theoretically, within first 10 days of the menstrual cycle, they can come to you. Even during menses, day 1, day 2, if they come to you, you can put a copper T, an IUCD, because at that time the cervical canal is open, the patient has less pain, and the uterine cavity is also distended. So it easily accommodates the IUCD. But there is a high rate of expulsion after abortion and delivery. So if we do it immediately after delivery, it can be done within 48 hours. Later on, if she wants to come, it can be done in the lactational amenorrhea period, anytime during lactational amenorrhea. Okay. After abortion, then you have to either do it immediately or call her within the first 10 days of her menstrual cycle. Government of India is promoting PPIUCD. That is why you got a question on that. Okay. Now, then there is something, interval insertion is 6 weeks after delivery. In case she doesn't come to you in the LAM period, or in case she wants to go back and come back to you, you can call her after 6 weeks, because they will generally not ovulate. Even if they are not breastfeeding, they will not ovulate within 6 weeks. So call her 6 weeks, 1.5 months after delivery. That is when the pubertal time is getting over. Now, next question. Patient with previous LSCS presented with PV bleeding at 37 weeks. 37 weeks, PV bleeding, previous LSCS. These are the pointers. So this is previous LSCS, APH, and this is 37 weeks. Bleeding could not be controlled, hence hysterectomy was done. Hysterectomy was done. So basically, she was either going through LSCS, she had an LSCS again, or she had a normal delivery. We don't know. Okay. So she either had an LSCS or a normal delivery. I don't know what else I'm missing in the stem, but it is very obvious that they have not mentioned anything about the baby. That means the baby was taken out safely. Accreta that, she ended up in hysterectomy. Now tell me, out of all these options, which is the most common cause of cesarean hysterectomy or hysterectomy after delivery? That is placenta accreta spectrum. Why I'm going retrospectively? Because I don't know exactly what they asked you. If they showed you any image, I was told that there was some image there which through which the placenta was coming out. The children said that there was a uterus in which the cotyledons could be seen. Now it can be anything. I'll show you some images that might help you understanding and recapitulating what you actually saw. But placenta accreta spectrum in previous LSCS is very, very likely to end up in hysterectomy. Okay, especially if the patient has not been managed well, she has not had an MRI to rule out placenta accreta, the proper management team was not there, methotrexate was not available. So everything has to be seen. So looking at the image, identify the condition. I don't have the image for you. How does a rupture uterus look like? A rupture uterus looks like this. Can you see the ruptured area? This is the rupture uterus. The entire wall has ruptured. Then similarly, this one I got from internet. Now the placenta is attached. This can also be a rupture. It doesn't look like a cesarean hysterectomy because when we cut the uterus, we will not have these ragged margins. So this is also looking like a rupture, but this is definitely a rupture uterus. Okay. Again, this is also a rupture uterus. It has been ruptured and you can see the placenta attached to it. This is a placenta accreta. This is a hysterectomy sample, a specimen in which the uterus has been bisected. It has been cut from longitudinally. So you can see the two halves of the uterus and you can see the placenta attached. Did you get this picture? I don't know, but the cotyledons are very clear. Okay, again, this is a picture of probably a rupture uterus or a placenta previa. Placenta previa definitely will not end up in hysterectomy. Rarely it will end up. Yes, there is a problem with the lower segment. Placenta previa means the placenta is implanted in the lower segment. Lower segments does not have that much oxytocin receptors. It is not as contractile. It does not have that much muscle. You know anatomy. All the interlacing muscles which act as living ligature in the uterus, they are not so dense in the lower segment. So that is the reason why the lower segment bleeds more in placenta previa. But ending up in hysterectomy, very rare. So all the pointers, PV bleeding, LSCS, 37 weeks, she had an LSCS, are pointing towards placenta accreta spectrum. So you need to recognize the image. Lot of image-based questions this time. Patient presented at 37 weeks for routine ANC. Patient is on warfarin. What will be the next step of management? Very, very important question. Switch to LMWH. Continue warfarin. You know warfarin is a very strong anticoagulant. It can lead to PPH. So we will not let her go into labor. You have to switch her on to LMWH, which is a less potent anticoagulant. Immediate vaginal delivery, immediate LSCS? No, not at all. You have to give her some time so that she recovers from the effect of warfarin. So now quickly recapitulating, anticoagulants are necessary in which conditions? Congenital heart diseases like pulmonary hypertension, artificial valvular replacements, and atrial fibrillation. During pregnancy, what is the choice of anticoagulant? It will depend upon the period of gestation. So right now our patient is 37 weeks. She's about to deliver. So we need to switch her over to LMWH. At 36 weeks, we will switch her over to LMWH because she can go into labor anytime after 36 weeks. And it will also depend upon the available anticoagulant, which because they have their own advantages and disadvantages. What are the advantages of warfarin? The advantage is it is a strong anticoagulant. But what is the disadvantage? It can cross the placenta and it can lead to chondrodysplasia in the fetus. So imagine the baby is getting affected. There is some chondrodysplasia, skeletal deformity in the baby happening. So then you will not want warfarin to be given in the first 12 weeks because that is the time when the baby is actually developing. First 12 weeks and the last 4 weeks between 36 to 40 because that is the time when she's going to deliver. In between, the warfarin is the best choice because it is a strong anticoagulant and it will take care of the disease. Heparin cannot cross the placenta. Okay, so that is again a good factor. That is an advantage. So that is the reason why you give heparin in the first 12 weeks when the baby is developing and the last 4 weeks when the patient is about to deliver. But it is a weak anticoagulant. So that is why during pregnancy till 36 weeks, we prefer warfarin. Warfarin treatment at the time of delivery or within 2 weeks needs to be counseled for cesarean. If the question was that the patient came to you at 37 weeks, she's in labor and she's already on warfarin. There was no time to switch her over to LMWH. What will you do now? You have to counsel her for cesarean because in cesarean you can manage the bleeding. In normal delivery, she might end up in PPH. It will be difficult because you don't have your hands ready, the patient's abdomen open to actually manage all these things. You cannot ligate anything. So if she ends up in PPH, that will be a problem. So because the mother can have PPH, so in that case, you have to counsel her for cesarean. Moreover, the baby is also anticoagulated. The baby is receiving so much warfarin, which is crossing the placenta. So this baby is going to bleed when you actually subject her for normal delivery. The baby coming out from the maternal pelvis, the entire birth canal, it is going to cause intracranial hemorrhage in the baby. So in that case, if she comes to you with warfarin, on warfarin, and she's properly anticoagulated and she's in labor, you have to counsel her for cesarean to save the mother as well as the baby. It is a strong anticoagulant. Fetal liver takes 2 weeks to metabolize warfarin. Okay. So period of gestation, again repeating the same. Less than 12 weeks, you have to give heparin. 12 to 36, warfarin. After 36, again heparin till 7 days postpartum. After 7 days, when the patient is coming back to normal, all the coagulation factors are coming back to normal, you can again continue warfarin because it is a stronger one. Then, a little difference between unfractionated and the LMWH. Okay, they may ask you this question. Switch over from warfarin to unfractionated or LMWH, but what is the choice? Preferably, we try unfractionated rather than LMWH. Why? Because it has a shorter half-life and protamide is a stronger antagonist against unfractionated as compared to LMWH. Just in case she starts bleeding, you need a antagonist. You need a drug which can antagonize the action of that heparin. So in that case, unfractionated, it has a proper antagonist. LMWH does not have. Okay. Stop all anticoagulants 6 to 8 hours before delivery. Even though the patient was already being switched over from warfarin to LMWH, even then you don't want her to bleed, to have PPH. It's basically an anticoagulant. So before delivery, planned cesarean or normal delivery, she's in labor. After delivery, if it was a normal delivery, you restart the anticoagulant 6 hours later. If it was a cesarean, obviously she has a big scar there, then you have to wait for at least 12 hours after cesarean. Warfarin or heparin, both are safe in breastfeeding. So breastfeeding is not a problem, either heparin or warfarin. Then a question on DSD. Children, mark it, you will get a question on DSD. That is a very important topic. I have been noticing the trend. Examiners love to ask you about the DSDs, the disorders of sexual development. So yes, you will get one question. I saw in both the first and the second shift, you got one question on DSD. Okay. 16-year-old patient presented with short height, primary amenorrhea. Short height just suddenly clicks in your mind, it is Turner syndrome. And they've given you a karyotype. That is very, very simple. Even if you don't know how to read karyotype, you can just mark it short height, primary amenorrhea, it is Turner syndrome. Swyer syndrome will be XY. You know, it is a dysgenetic kidney. MRKH will be XX. There will be a double X. Androgen insensitivity will again be XY. So X0 is Turner syndrome. Okay. The indication to stop magnesium sulfate. I'm not going to the details of DSD because you have to go through the app where I've explained it properly in the crash course also, in the proper lectures also, and we'll be soon doing a ionisate prepathon. You can join that. Now, indication to stop magnesium sulfate. Respiratory rate 18 per minute, that is normal. Urine output 60 ml in 4 hours. That means how much in 1 hour? So it will be around 15 ml per hour. That's very less. What we have read, it has to be minimum 30 ml per hour. So that definitely is an indication to stop magnesium sulfate, because then what will happen? The magnesium will accumulate in the body and it will lead to magnesium toxicity. Knee reflex is present. Yes, very good. Onset of visual disturbances. Onset of visual disturbances is not because of magnesium sulfate toxicity. It is because of the eclampsia, the pre-eclampsia. Probably you need to terminate the pregnancy or you need to increase the dose of magnesium sulfate, whatever infusion dose you are giving. But definitely it is not linked to magnesium toxicity. Okay. Now, therapeutic range of magnesium sulfate. Let us just quickly recapitulate this. Therapeutic range of magnesium sulfate is very, very small. It is about 4 to 7 milliequivalents per liter, 2 to 3.5 millimoles per liter, or 4.8 to 8.4 milligrams per liter. So it is milliequivalents, millimoles, and milligrams. If you can remember the numbers, this is very important. Others also may be asked just to confuse you. After all, it's ionisate coming. Okay. So before repeating the IM dose after 4 hours, you check for the toxicity. So you don't check the magnesium levels. Okay. That is another question in the second shift. What do you not check? You don't do proper magnesium level checking because that is not recommended by ACOG. Okay. That is just time consuming and unnecessarily using the resources. So what you're doing is you are checking the urine output, the deep tendon reflexes, the respiratory rate, and the pulse oximetry. This fourth point was not given in your question. In your question, they have given you the visual disturbances just to confuse you. So visual disturbances are happening because the preeclampsia is kind of progressing. You're not able to control it with magnesium sulfate. It is not magnesium toxicity. Okay. So urine output should be at least 30 ml per hour or more than 100 ml per hour. Deep tendon reflexes should be present. Respiration more than 12 is good. Pulse oximetry on air should be more than 96%. Regimens for magnesium sulfate, you know it is a Pritchard regimen. Repeat injection are given only if 1 to 4 of the above are present. So what are the regimen? Pritchard regimen, you know, 4 gram IV bolus in 20 ml. So it is a 20% solution. 4 gram means it is 8 ml of magnesium sulfate and 12 ml of NS, and you mix it together and give it IV in slow in 10-15 minutes, and 5 gram directly without diluting into the buttocks on the right and 5 on the left. So basically 5 plus 5 plus 4, 14 grams you are giving loading dose. Followed by that, you go for a infusion. So the maintenance dose, before you give that, you check all these 4 criteria, whether it is present or not. If any of these, if only even one is absent, maintenance dose after 4 hours is omitted, you can give it after 8 hours. In between, you do a magnesium level. You check for the magnesium level. If it is crossing the therapeutic level, means it is crossing 7 milliequivalents per liter, then you may give an antidote. Okay, then you may give an antidote. Now, ACOG 2020 does not recommend routine check for magnesium serum values. So basically, it was there in the lectures and the question has come as such. Okay, so if you have read the lectures properly, heard the lectures properly, you will know the answer. What should be the mode of delivery in the two cases of twin pregnancy shown below? Simple. First twin breech, it has to be LSCS, and the first twin is cephalic, then it has to be normal delivery. So definitely this is the option. How do you manage labor in twins? Mode of delivery, the first twin has to be cephalic, then you go for a vaginal delivery. First twin cephalic and second also cephalic, both can have vaginal deliveries. Okay. Now, if the first twin is breech or transverse, you have to always go for cesarean section. There was a lot of discussion in the group going on why we can't do a frank breech delivery even if the first twin is breech. No, first twin breech, you don't go for a normal delivery. There is no fixed time interval between the delivery of first or second twin. Definitely, it has to be generally expedited by forceps or vacuum after a lapse of 30 minutes. If the baby does not deliver the second twin within 30 minutes after the delivery of first twin, then you go for a forceps delivery or ventouse delivery. You have to actively manage it. Most common presentation of twins is both cephalic. Second most common is first cephalic, second breech, as they've shown you in the photo, in the picture. Now, how do you manage it during labor? Liberal episiotomy, because breech will need some manipulation, breech extraction, assisted breech delivery. So you need a liberal episiotomy. Pudendal block for the forceps, yes. And after delivery of the first twin, you do not have to give methyl ergometrine. Otherwise, it will lead to contraction of the cervix, and you don't want the second twin to be entrapped inside. At least 8 to 10 centimeters of the cord has to be left so that you can administer some drugs. Okay. Delivery of the second twin. Soon after delivery of the first twin, you have to perform an abdominal examination to determine the lie of the second twin. Sometimes once the first twin comes out, the second twin sometimes changes its position. From transverse, it becomes breech or cephalic, and that becomes easier for you. It comes in a longitudinal lie. In a longitudinal lie, it becomes easy. You can do a podalic, you can do a assisted breech delivery, you can do a breech extraction, you can sometimes even do an internal podalic version. If the cephalic position of the baby is not coming down, you can go inside. It's a small baby, the second twin is generally smaller. You have space, you catch hold of the feet and you do an internal podalic version. So if the second twin is longitudinal, wait for a few minutes for the descent of the presenting part. If the crown is not coming down, you can do an internal podalic version, or you can just give a fundal pressure so that the baby comes down. Do a vaginal examination, exclude there is cord presentation. There is no cord presentation. You don't want the cord to come out, otherwise there will be a risk for the baby to die. Rupture the membranes, release the liga carefully. Go very, very, very slow, controlled ARM, and then you do the second twin delivery. Commence an oxytocin infusion. Sometimes after delivery of the first twin, the pain suddenly stops. So you have to give her augmentation. Contractions, if they do not return within 5 to 10 minutes, start oxytocin. Deliver the second twin as soon as possible. If there is a delay of more than 30 minutes, use forceps. You can do external cephalic version. You can do internal podalic version. You can even do LSCS. Okay. Give a bolus of 5 units of oxytocin after the delivery of the anterior shoulder. So it is AMTSL, that is active management, because you are suspecting PPH in a patient with twins. So as soon as the second twin's shoulder is coming out, you have to give oxytocin IV and conduct active management of the third stage. Delayed delivery of the second twin is associated with perinatal death and maternal infection. Perinatal deaths are kind of linked with second twin. Okay. Then, if the first twin is cephalic, normal vaginal delivery, second twin breech, assisted breech delivery. Okay. That was the case given to you in the first case. First was cephalic and the second was breech. If the first twin is cephalic, normal vaginal delivery, second twin is transverse. Sometimes it will change its position. From transverse, it becomes longitudinal as soon as the first baby comes out. That becomes easier. If it does not, then you may do either an external cephalic version if you have not ruptured the membranes. If you have ruptured the membranes, then you can go for internal podalic version. And this is the only indication for IPV, that is internal podalic version, that is a second twin when it is transverse. Okay, internal podalic version is done, make it breech, do a breech extraction. Internal podalic version, just quickly finishing, OT procedure, it is done under GA, it is difficult, okay. You have to relax the uterus. It consists of turning the lie of the fetus by inserting a hand into the uterine cavity, holding the feet or both the feet of the baby, either one foot or both the feet, and making them breech. You have to be very careful, don't break the baby's femur or the foot, and this should be followed by a breech extraction. It carries a risk of uterine rupture, so you have to be very careful. Only indication for IPV is the second twin transverse. Absolute contraindication in previous LSCS. So that was again a question. Internal podalic version when it is not done. Okay. Indications of cesarean in twins. Let's quickly recapitulate all this because this was asked in the question when you will not do a cesarean. So when do we do a cesarean? In twins, elective cesarean. Elective delivery is done when it is a conjoined twin. Yes. Monoamniotic when they are both sharing one sac. There is a high risk of entanglement, cord prolapse, fetal deaths. Twin-twin transfusion in monochorionic twins. You will not go for a normal delivery, go for a cesarean. Baby, first baby not cephalic, as was the second case. Fetal growth restriction in dichorionic twins. There is a growth restriction, discordancy, placenta previa, contracted pelvis, previous LSCS, and severe preeclampsia. Any obstetric condition where already normal delivery is risky. In twin delivery, you will not take the risk. For indications of emergency cesarean, obviously, if there is a fetal distress, if there is a cord prolapse in any of the babies, non-progress of labor, it is not progressing, collision of both the twins. You know, sometimes when the first baby is also cephalic and the second one is also cephalic, there may be a collision. Sometimes at the pubic symphysis, sometimes just at the lower segment, they might collide, and the other one is not giving way to the other one. So it is like pehle aap karne, pehle aap jaiye. So none of them are actually doing that. So they are both trying to come out at one go. So that is a collision at the pelvic rim. So in that case, you have to do a cesarean. Now, indication of cesarean in the second twin. Obviously, when there is fetal distress, when the first baby delivers under GA, then you cannot wait for the second twin to deliver, because GA will already make the baby very, very sluggish. Severe intrapartum bleeding after delivery of the first twin. Second twin is transverse and internal podalic version is also not working. Large second twin weighing more than 3.5 kg. That is rare, but it can happen. Sometimes the second twin is bigger than the first twin. Cord prolapse has happened, again fetal distress. Prompt closure of the cervix. You have not given ergometrine, or you have given ergometrine and it has closed. So you have to do a cesarean for the second twin. So this is all about twin management during labor. Now, patient came to you for abortion at 10 weeks. Again, a hypothetical question. It is definitely not recommended to do medical abortion with misoprostol and mifepristone at 10 weeks. Definitely not. But there is a table in Williams and in your other books also that up to 12 weeks, we can give miso plus mifepristone. We can give plain miso. We can combine miso with methotrexate. So it is 3 M's and even T, that is tamoxifen. I will show you the options. So here the answer is mifepristone and misoprostol. We will not give intraamniotic ethacridine. It is used for second trimester. Oxytocin, no. It is again combined with the intraamniotic or extraamniotic methods of second trimester abortion. Simply giving oxytocin will not work, and dinoprostone again not used in the first trimester. Now, in India, initially, MTP with medical termination of pregnancy with miso and mifepristone was recommended till 7 weeks, but now it is up to 9 weeks. Okay, but still they've asked to 10 weeks. So if the patient is insisting, then you can give her miso plus mife, explaining her all the risks. Now, what are the regimens? First trimester up to 12 weeks. It can be simply mifo. It can be M plus M, that is mife plus miso. It can be methotrexate plus miso, or it can be tamoxifen plus miso. So it is M3 and T. Okay, surgically we can do menstrual regulation, which is not done anymore. Still in some obsolete colleges, it is still being done. In some obsolete medical like government colleges, government hospitals, it is still being done. Manual vacuum aspiration, that is MVA, where we do not have a facility of electricity and suction machine. Suction evacuation most commonly done, and DNC, rapid method or slow method. You use dilators or you use laminaria tent for slow dilatation of the cervix. Second trimester, medically, we can use all the misos, all the M's, M, mife, miso, but they are not using methotrexate here. I don't know why they have not mentioned, but maybe it may be used, but it is not a drug that we normally use. It is an anti-cancer drug. We don't use it for abortion, even in the first trimester. So if they ask you, you can just have a very high threshold that I will not mark methotrexate for abortion at all. That option has to be erased from your mind, even though if it is written in the first trimester. So it is mife, plus miso or plain miso, or sometimes dinoprostone. So dinoprostone was not there in the first trimester, and carbopros was not there in the first trimester. These two are additions in the second trimester. Then intrauterine instillation of hyperosmotic saline from 16 to 20 weeks, because after 16 weeks the amniotic cavity is full of amniotic fluid. That is the reason why we do amniocentesis after 16 weeks. Ideally after 16, although it is recommended after 14 also. But after 16, between 16 to 20, we get good amount of amniotic fluid. That is the time when we do intraamniotic or extraamniotic instillation of hypertonic saline along with oxytocin, prostaglandins. We mix all this and we inject it inside. Okay. Surgically for second trimester, either do a DNC only up till 15 weeks. Up till 15 weeks, the baby's bones are soft. You can go in with the instrument. You can do a DNC. You can pull out the baby piecemeal. Not a very nice thing to say, not a very nice thing to see also. But yes, it is recommended till 15 weeks. If the gynecologist wants to do, she can do it. Hysterotomy means you are making a hole in the uterus and you basically cutting this part and you extracting the baby out. It is not a cesarean, it is hysterotomy. You have to go in the upper segment because it is very difficult to go in the lower segment. There is no lower segment form. So you have to go generally in the upper segment, and that is hysterotomy abdominally. It is less commonly done unless the baby is really stuck inside. Then you have to do a hysterotomy. So these are the two regimens for first and the second trimester. Then, 28-year-old woman presents with mass protruding out of vagina. Now, I don't know what kind of picture they showed you. She wants to preserve her fertility. Mass protruding, it can be a polyp, it can be prolapse. So, looking at the options, we know it was prolapse. That is why they've given you all the options of prolapse surgeries. So, Lee-Fort's colpocesis, you should be clear. Lee-Fort's means you are basically obliterating the vaginal cavity. Anterior posterior walls, you create a raw area here, and you stick them together. You stitch them together. So basically, she cannot have intercourse at all. So in a young 28-year-old woman, you will not do that. Okay. Then there is another word. I forgot the name of that colpocesis. I will just go through the theory. It is partial colpocesis. In that case, you leave some space in between the anterior and the posterior walls. You stitch them together. Maybe leave some space for the intercourse to happen. Okay. So it is not done before 65 years of age. Further operation is done in a young patient, yes, but only when she does not want any more children. Further is again a kind of, it is preserving the menstrual function. It is not preserving the fertility. The patient cannot get pregnant again, but yes, she can have menses, okay, if she wants to retain the uterus. Metcalfe's cultoplasty. What is cultoplasty? Cultoplasty is basically when you are trying to reduce the pouch of Douglas. When you are, this is the uterus here, okay, and this is the rectum here. So this is the POD. The POD has intestinal loops. So this is basically preventing enterocele. So you do a cultoplasty when you want to obliterate this space so that the intestines go inside the abdomen and they do not prolapse through the vaginal wall. So it has no use here. Okay, it is a prolapse here. So basically what we will go with is mesh repair. You pull the uterus up so that she can have some support to the uterus. Mesh, I will tell you, it can be stitched with the sacral promontory. It can be stitched with the anterior superior iliac spine, with the rectus sheath. So it's something holding it up, and that patient can conceive later. Although it is going to kind of not destroy, I would say, but it is going to reduce the effectivity of this surgery if she delivers again. But she may have a cesarean. Okay. Now, types of surgeries for prolapse. We can have restorative, when what is actually required in this question. Correct the patient's own supportive tissues or use grafts to correct. That is mesh repair. Extirpative means you're removing it. Okay. Remove the uterus and correct the supporting tissue. That is vaginal hysterectomy. Then the other one is obliterative, when you actually colpocesis. You're closing the vagina. That is done in old patients. Right. So extirpative, restorative, and obliterative. Now, it depends upon the patient's age, parity, her desire to preserve her menstrual function or fertility, degree of prolapse, type of prolapse, what kind of cystocele, rectocele, walled prolapse, what it is. Prior prolapse surgeries, whether it was effective or not, associated morbidities, associated other problems. They might sometimes tell you that the patient is having heart disease, she's not fit for surgery. In that case, colpocesis will be the answer. Okay. Now, vaginal wall, when it is descending, first of all, vaginal wall can present as cystocele or rectocele. Okay. So, anterior, posterior, and posterior 2/3 and posterior 1/3. So posterior upper 1/3 will be enterocele, that is the pouch of Douglas, and the lower 1/3 will be rectocele. So what do we do here? We do a pelvic floor repair, also known as posterior repair or colpoperenniorrhaphy. Here we write it as anterior repair or anterior colporrhaphy. Okay, that is the name of the surgery. Vaginal wall surgery has no relation with age or parity. She can conceive, she can deliver, whatever is her age. If she just has vaginal wall coming out, cystocele, rectocele, enterocele, you can do this kind of surgery in any patient. Okay. In the posterior one, when I told you it is enterocele, we have to obliterate the pouch. So how do we do it? We either do it vaginally while we are doing the surgery. So when we do it vaginally, it is known as McCall's cultoplasty. So this is the pouch. So you're basically putting sutures like this. So you actually go like this, but it is not possible to do it vaginally. So when we do vaginally, we just take one stitch all around and we close it like a purse, just like a purse string. So this is how we do it vaginally. Abdominally, we can do it both ways. We can either put a stitch all around and just close it like a purse. So that is known as Moskowitz repair. Or when we go like this, longitudinally obliterating the entire space, that is Halban's repair. Okay. So that is cultoplasty. Combined anterior posterior cystocele and rectocele, we do a combined colpoperenniorrhaphy, or we do a PFR, pelvic floor repair, combined. Uterovaginal, when it is a uterus, uterovaginal prolapse, uterocervical prolapse actually, when there is no vaginal prolapse. In that case, we do a vaginal hysterectomy with pelvic floor repair if it is required. We do a Fothergill when the patient wants to preserve her uterus just for the menstrual function, or we do a sling surgery when she wants to preserve her fertility also. What was the question in this one? This question was actually, the answer was sling surgery. Vaginal wall after hysterectomy, if it is a vault which is coming out, simply wall prolapse, that is a nasty one. We don't have anything to remove now. It is just the vaginal wall everting outside. So we can do a vaginal repair or we can do a abdominal repair. As I told you, vaginal repair will be either during vaginal hysterectomy, we do a pelvic floor repair, we tie the uterosacrus along with the vaginal wall so that after hysterectomy, after a couple of years, she does not come back with vaginal wall prolapse. So at that time of vaginal hysterectomy, you tie the vaginal wall, you support it with the uterosacrus. If you have not done that, she comes back with prolapse. Sacrospinous colpopexy. Sacrospinous means you pass a Mayo's, that's a Mayo's needle, a Mayo needle. Okay, simple Mayo. Mayo's needle is passed. It has an angulation and you just feel the ischial spine. So basically, you just turn the needle. It has an angulation. You are hooking the vaginal vault along with the sacrospinous ligament. You can just feel the sacrospinous ligament, but it is difficult. So you go through the ischial spine and you feel it. Yes, it is a projecting thing, and just blindly hook it through the sacrospinous ligament, and you fix on both the sides of the vaginal wall. That is known as sacrospinous ligament. So the bony prominence that you're using in the vaginal fixation is the ischial spine, okay, not the ischial tuberosity. And when you're doing it abdominally, then it will be sacrocolpopexy. Sacral colpopexy means you are going through the sacral promontory. Again, a question in the second shift. They showed you a picture. So when you're doing it abdominally, the bony prominence is sacral promontory. Vaginally, you cannot go up to the sacrum. So you have to go to the ischial spine and you hook it with the sacrospinous ligament. And the other thing is, as I told you, if she's old, doesn't want to preserve her sexual function, then you can do a colpoplesis. Just obliterate the entire thing so that it doesn't come out. Uterus without the vaginal walls, if it is simply nulliparous prolapse, piston prolapse, what do you call it? Piston, it is coming out like a piston prolapse. You can do a cervicopexy. You can reduce the length of the cervix. It is simply cervical elongation to a further gills, or you can fix the cervix up, or you can do a sling Purandir operation. The Purandir operations, the Khanna's operations, all these can be done. Now, vaginal prolapse treatment does not depend upon the age and parity. As I told you, you can do an anterior colporrhaphy. Anterior repair means you're pushing the bladder up, the cystocele, you're reducing the space, you're reducing the redundant skin, and you're just pushing it up. Posterior colpoperilorrhaphy, same thing. Anterocele abdominal is Moskowitz when you're going purse string. Halban is longitudinal repair, and vaginal is McCall's cultoplasty. You take a purse string and you just close it. Okay. Anterior sling surgery and posterior sling surgery. You need to know that. Anterior sling surgery means you are fixing the uterus to something anteriorly. That means rectus sheath. Okay. So the rectus sheath, when it is fixed to the rectus sheath, it is known as Purandir. Rectus sheath is something which is not static. It is dynamic. So your tummy might bulge when you eat a lot. Your tummy might go in. So rectus sheath is kind of moving with your breathing movements also. So it is a dynamic thing. It is an open sling because it is not attached to a fixed structure. So it has less complications, but success rate is also less. The other thing that came in was after Purandir was a Shirodkar, which was a posterior sling. Then there was another one that is fixing the uterus to the anterior superior iliac spine. That was Khanna. This is obsolete because it can lead to damage to the anterior superior iliac spine. We know where it is, the anterior superior iliac spine. We can all feel it unless you're very, very fat. Anterior superior iliac spine juts out from just pelvis, the iliac bone. And if it is fixed, the uterus is fixed to that spine. That was known as Khanna's operation. It is obsolete, so we don't do it. So the two sling surgeries that you need to know is Purandir, anterior sling, less complications but less successful. Posterior is Shirodkar when you're fixing it to the sacral promontory. That was the picture that I showed you in the second shift. Static sling because sacral promontory doesn't move. Marceline tape is attached to the posterior surface of the isthmus of the uterus. So basically we're catching hold of the isthmus, this part of the uterus, and fixing it with the fascia lata to either the rectus sheath or with a mesh to the sacral promontory. And this is definitely more successful, but it has more complications also. Okay. And when we are doing an anterior sling surgery, remember we have to do a cul-de-sac obliteration also because you're fixing the uterus anteriorly. So remember, there's a pouch of Douglas. So if you fix this uterus anteriorly, this pouch is going to get bigger. So you're basically making the pouch of Douglas bigger. So you have to do a Moskowitz repair. You have to either obliterate it with the Moskowitz purse string suture, or you do a Hallbund's repair and completely obliterate it so that you don't end up with enterocele. Okay, children, Purandir and Khanna is not done anymore, and Shirodkar. Sometimes we may do a combination of Purandir and Shirodkar, and that is known as Virkut slip. Why? Because when you do a Shirodkar, when you are going behind to the sacral promontory, on the left side there is a big sigmoid colon. You may damage that. You may damage the mesentery. So posteriorly, when you're doing a Shirodkar, do it on the right side, not the left side. On the left side, you can do a Purandir. You can fix the left side to the anterior, the rectus sheath, and posteriorly you can go to the sacral promontory. So that is how we do a Virkut composite sling, fixing the uterus two parts. Okay. Fothergill, Manchester, it is done under 40 years, but it is only for the women desiring menstrual function. It is not done in women who desire future pregnancy because it is not going to work. Also, it is done in case of cervical elongation. You cut the cervix. I'm not going to the details. You can go through the lectures in Manipal Medes. So we cut the cervix, we do a sturmed off suture, and we make a new cervix through the vaginal wall, and this is how Fothergill operation is done. Lee Ford colpoclesis done after 60. Medical complications, management of third degree prolapse or even vault prolapse when actually she's not fit for surgery, and a kind of vault prolapse which is recurring. It is not possible to do a surgery, fix it to the sacral promontory. So just do a colpoclesis, just obliterate everything. Again, similar question for vaginal sling surgery, which is taken as bony protuberance. I just told you, when we do a vaginal sling surgery, we are not opening the abdomen, we are putting a sling in the vagina. I hope this was the stem of the question. In that case, I will go with ischial spine because it is known as sacrospinous fixation. There is a strong ligament, the sacrospinous ligament, sacrospinous fixation. You can fix the vault with it, and it is generally used for vault repair. Not many people are trained for that, but if you have the Mayo needle and you're trained for that, it is a very simple procedure, very less morbidity. You don't open anything. So morbidity is less, blood loss is less. Okay. Vault prolapse, the vaginal approach. Repair of endocele with PFR, that is when you are having vault prolapse and you're having enterocele also. The pouch of Douglas is having intestinal loops coming out and there is a vault prolapsing. Okay, so the vault, the vagina is coming out and posteriorly the enterocele is also coming out. In that case, you have to do a pelvic floor repair. You have to push the intestines back. You have to obliterate the cul-de-sac and you have to do a vault repair. Lee Ford colpoclesis in patients who are unfit. Sacrospinous fixation, as I told you, the Mia hook. Sorry, it was not Mayo, it was Mia. My bad. Recurrence is 3% in this case. So it is a Mia hook. Abdominal approach, as I told you, transabdominally sacrocolpopexy. You fix it with the sacral promontory. It is the gold standard surgery for vault prolapse. Okay. Now, next question. Tubectomy is done in ampulla because it is wide. Ampulla because it is equal amount of circular longitudinal muscles. Isthmus because it is narrowest. Isthmus because it has longitudinal muscle only. Remember in my lectures I have told you, if this patient goes for a reversal, it is always good to have a isthmic ligation because isthmus is the narrowest part, right? Ligating will be easy because if you are ligating a part which is kind of big and has a very varied diameter, this diameter is different, this diameter is different, so it is variegated, it is not having a uniform diameter, it will be difficult to ligate. You may leave some part unligated, there may be some communication happening and the tube might join. Moreover, when you do a reversal, in that case it will be very difficult to rejoin these two unequal parts. For example, if you have cut here, one part will be this big and the other part will be this big. How will you rejoin them? So isthmus always, because it is the narrowest part, that is why we do a ligation here. It is easily obliterated with the help of clips, ring, or whatever suture you are doing, whatever method you are doing, and it is easier to open also. Okay. Then next question, ECV can be done in which case? So now we know the prerequisites and we know what are the contraindications. Okay. If you don't know, we'll just quickly recapitulate. Contraindications for ECV are absolute contraindication when there is a grossly anomalous fetus. 15% chances are there that the breech baby might be having a congenital anomaly. In that case, why will you do a ECV? Okay, you can just simply do a cesarean and deliver the baby. Structural uterine abnormalities, when the uterus is also already abnormal, bicornuate, septate, you will end up in uterine rupture. 3 varieties of breech in which we don't do ECV. One is a stargazing because you know this neck is going to get stuck in the aftercoming head. When the baby is a footling breech, the foot is coming out. In that case, how will you do an ECV? And knee presentation. These are the 3 rare cases in which we don't do ECV. Then macroscomic baby. Such babies who are more than 4 kg, how will you do an ECV? They will not deliver. Okay, you have to go for a cesarean section. Placenta previa, multifetal, we don't do ECV because there is no place. And wherever vaginal delivery is contraindicated, for example, contracted pelvis. Okay, so these were the questions here. Multiple pregnancy, you will not do ECV. Placenta previa, you will not do. History of classical, already there is a risk of rupture and you do an ECV and you rupture the uterus. So the answer here is primary gravida is not a contraindication. You can do ECV in prime. Then other contraindications for ECV are active phase of labor, abnormal fetal heart rate. Obviously, with the patient is having labor or the baby is not happy, the fetal distress, and you're trying to move the baby, not possible. Oligohydramnion, you need a proper Liker volume there. So prerequisite is that the baby should be fine. It should be after 37 weeks, not preterm. Then there should not be any abnormality in the uterus. Moreover, the heart rate should be fine. They should not be in labor. The amount of liquid, the amniotic fluid should be good enough for the baby to move inside. Rupture of membranes should not be there. Otherwise, what will ECV do? It will just kind of create more complications. Known case of nuchal cord, there's a cord around the neck. Why will you do an ECV and make it more tight? Then relative contraindications are when the baby is growth retarded, you don't want to compromise. PIH is there, heart disease, previous cesarean. Previous cesarean, I would say, is not a relative; it is an absolute. But in your books, it is written it is a relative contraindication. So especially classical will be an absolute. Previous lower segment, it is a relative contraindication. Okay. Then, so this is how we do an ECV. Let's just skip this slide. Confirm the diagnosis, variety of B. We know which variety we're not doing. Congenital anomaly, fetal weight should not be more than 4 kg. Check for the prerequisites for ECV. What are the prerequisites? Gestation more than 36, Liker adequate, membrane intact, no contraindication, no CPD. Emergency cesarean facility should be there. Early labor should be there. Not you can do it before labor or in early labor, not in active. Next, ovarian serous cystadenoma markers. Now, this is a wrong question because whatever options I could get from the children, I don't think there was a simple option of CA125. All the combinations for a serous cystadenoma are wrong. The only tumor marker is CA125. You have to mug up this chart. Very important. I'm sure Dr. Ranjana in pathology will be covering this question also. So, non-mucinous epithelial serous cystadenoma, the only marker is CA125. When it comes to CA19-9 and CEA, that is mucinous, yolk sac will be AFP, antitrypsin LDH, choreo will always be HCG, dysgenoma will be having a combination LDH, HCG, all will be there, and placental ALP. Embryonal tumors will have both HCG, AFP, so there will be a combination of yolk sac and choreo. Granulosa cell tumors will have inhibin because granulosa cells they secrete inhibin B. Okay, so it will be inhibin B. Then, time taken from A to B. Again, I'm not sure what diagram you got. Basically, you know that 3 days the zygote stays in the tube, and on the 4th day it starts moving. 5th day the implantation starts happening. It is not complete. It takes almost 10 days to complete. But most of you have actually marked 5 days. There may be a difference in the stem. There may be a difference in the diagram that I have picked up. So A is this when the fertilization is happening. B is when the implantation is happening. So when it is a complete implantation, children, it takes about 10 days. But when the implantation starts, it is 5th day. So it depends upon the stem of the question. So fertilization happens in the ampulla. After around 30 hours, 2-cell stage, then again 4-cell stage, then it becomes 8-cell. 16-cell stage is known as modula or the mulberry shape. After 3 days, till 3 days zygote is in the fallopian tube. That is 3 days means 14 plus 3. 14th day is ovulation plus 3. 17th till day 17 it is in the fallopian tube. Day 4, day 18, that means 14 plus 4 is 18. After fertilization, it is in the morula stage, starts moving into the uterine cavity. Day 5 is day 19. That is day 5 after fertilization. Zona pellucida hatching is happening. Blastocyst is basically forming because fluid is entering into the morula. So now it will become like this. This is the blastocyst and it is now attaching to the endometrium. So if they have asked you when the implantation is starting, it is 5th day. When it is completing, it is around day 24 to 25 of the cycle, means day 10 after 10 days of fertilization. So it begins at 6 to 7 days post fertilization, that is the implantation window, finishes at day 10. Most common site for implantation is the posterior surface of the uterus, that is the posterior upper two-third of the uterus. And the next most common site is the anterior one-third. So posterior two-third and anterior one-third. Okay. Now, identify the causative agent when the fetus suffers from very simple question, the triad of toxoplasma, chorioretinitis, hydrocephalus, and intracranial calcifications. So, just recapitulate this. In CMV, you don't get hydrocephalus, you get periventricular calcifications and you get microcephaly, not hydrocephalus. Okay, then you get retinopathy and chorioretinitis. So, chorioretinitis is there, yes. Intracranial calcifications, no, it is periventricular calcification. Okay, and sensory neural hearing loss in the neonates. In toxoplasma, the triad is intracerebral calcification, not periventricular, hydrocephalus and chorioretinitis. Rest all you can read. You must have read it. If you have not read it, just go through my crash course. Okay. Now, infected neonates with clinical signs are at risk for long-term complications in toxoplasmosis. Identify the image. Again, I have not showed you the image because I don't know what image they showed you, but I picked up the options that children were telling me, and most of you have actually marked polyp. Okay, so let us see what adenomyosis, fibroid, myomatosis, and polyp looks like. Now, what do you think this is? This is definitely multiple fibroids. You know, the other name for fibroid is adenomyoma. Okay, so this is also a kind of myomatosis. This is a polyp. This is a polyp, right? This polyp can hang sometimes. It can come like this also. This will also be a polyp. It is again a fibroid thing, but it depends upon whether it is adenomatous or adenoma polyp. Okay, whether it's an endometrial polyp or it is a fibroid polyp. If it is a fibroid polyp, it will have muscular tissue also. If it is simply endometrial polyp, simply endometrial hyperplasia, giving rise to these kind of polyp coming from the endometrium only, that will be an endometrial polyp, depending upon the pathology. The pathologist will tell you. So that is a polyp here. This one is a fibroid or adenomyoma, multiple fibroids, multiple adenomyomas, and this is a Halban sign. That means a uniformly enlarged uterus. You can see the type of muscular hypertrophy is happening, and the islands of endometriosis that you can see inside within the myometrium. This is adenomyosis, which is also known as endometriosis interna, because it is happening within the uterus. Endometriosis interna. Interna. It is not externa. When the endometrial tissue is found outside the uterus, pouch of Douglas, bladder, ureter, that is all externa. When it is within the myometrium, it is interna, also known as adenomyosis. Okay. The other picture I want to show you is the difference between adenomyosis versus fibroid. So this is a fibroid because it has a shell, it has muscular tissue inside. This is simply, although not a very good picture, but the adenomyosis is kind of localized. So it will not be that protruding. It will not be so protruding like this, but it will be, yes, it may be more like a kind of, you can say, focal adenomyosis. It will not look as white because it does not have any muscular tissue. It does not have any fibrous tissue. It is not fibromuscular. It is simply myometrium getting trapped or getting attacked by the endometrium. So it looks blackish, okay, and kind of hypertrophic myometrium. And this is the cut section of myomas and adenomyosis. So you can differentiate. Now, there's another word known as IV leiomyomatosis. So they might ask you that. So wandering or parasitic fibroid is one of the type of rarest fibroids, pedunculated subserous fibroids with no connection to the uterus. So just like secondary pregnancy can happen, it can detach itself from the uterus and placenta can get implanted into the liver or some vascular organ. Similarly, the fibroid gets detached from the uterus, cuts itself from the uterus and gets attached to some vascular organ to get the blood supply. So that is a wandering or parasitic fibroid. This is a CT scan picture. IV leiomatosis. So we know the blood vessels are thin. So basically the fibroid goes inside it and the fibroid is kind of taking shape of the blood vessel. So this is IV leo, disseminated intraperitoneal leiomyomatosis, which is also known as intravenous leiomyomatosis. You may get this picture. So I don't know what picture they showed you. Okay. So these are polypoid-like projections and they can suddenly cause death because if they enter the main cardiopulmonary circulation, they're going to just simply cause sudden death. Okay. Next question. 26-year-old with infertility showed a bilateral corneal block on HSG. What should be the next step? Now, you know the most common cause of bilateral corneal block is a physiological spasm. Physiological spasm happens because of the vasovagal. Physiological spasm happens because of the pain, the vasovagal stimulation suddenly, and the tubes, they undergo spasm. So yes, she will need a confirmation by a laparoscopic chromopertubation. You can also be given a DHL, that is diagnostic histolaparoscopy, or a laparoscopic dye insufflation test. There are different names to that. Basically, you're relaxing the patient, putting her under GA so that the pain is not there. Then you do the same thing. You put the dye from the vagina, you put the cannula, the Carman's cannula, inject the dye, and then you see with your naked eye whether the dye is actually filling up in the tubes or not. So that is the way of confirming whether actually she has a corneal spasm. Okay, because it is a bilateral corneal block, they're telling you. If it is a unilateral, one tube is showing and the other one is blocked, then generally it is true. It is definitely true that, okay, one tube is open, the other one is not. Okay, generally it is not false positive. But in case it is a bilateral corneal spasm, means maybe there was pain which led to this. So then you have to confirm with laparoscopy. But sometimes even in HSG, sometimes one tube may be blocked at the corner, the other one might be showing a free spill. Why does that happen? Because sometimes the dye is actually just filling up in one tube which has a larger opening, or probably it is a longer tube, so the entire dye has gone there. This one did not get a proper dye in circulation, or sometimes there may be some fibrotic tissue here. So when you do it with laparoscopy with a lot of force, when the patient is not in pain, you may end up opening this tube also. Okay, so but generally bilateral corneal spasm is physiological. You have to confirm with laparoscopic chromopertubation. I hope there is no confusion in this. IVF, IUI, or ARTs, artificial reproductive techniques, and adhesiolysis is not supposed to be done. There is no adhesion here. Okay. Then identify the uterine malformation. I was told by the student that we were shown two cervices. So I just took a picture from the Google which shows two cervix. Cervix 1 and cervix 2. Now remember, there are different classes of the uterine malformations. Class 1, 2, 3, 4, 5, 6. So class 1 is when there is no uterus. Class 2 is when there is half of the uterus, means unicornate uterus. Class 3 is when two uterus are developing with two cervixes. Okay, so that is two of them are growing together. That is a uterus diadelphous when there are two entirely different uterus with different vagina and different cervix. Okay, or maybe two cervix opening in one vagina. Okay, then the fourth will be a biconate. Partially they have kind of mixed together, so they kind of fused together partially, but it is still a biconate. Single cervix, lower part has fused, the upper part is still not fused. Fifth will be a septate, means they have fused together, but the septa is still left. And sixth will be the diethyl stilbestrol. So all these classes you need to know, and this is definitely uterus diadelphous. Unicornate uterus with a rudimentary horn. It does not look like that. It will not have two cervixes. So how does a unicornate uterus look like? This is a unicornate uterus. They may sometimes show you a horn here which is full of blood because it is not communicating. So it is a non-communicating rudimentary horn which has to be removed because it is collecting blood all the time. She menstruates and she will come up with pain and lot of a big lump in the abdomen, and it will be a tremendous pain which needs to be immediately operated. Okay, so normal. Then this is arcuate when simply the bulge is there, the dip is there, the dip of the fundus is there, that is arcuate, doesn't need any treatment. It may be confused with septate because this septa sometimes the arcuate uterus may look like a septate uterus. This is biconate, cervix is one, this is diadelphous. So here they've shown you one cervix, but actually it is two, one here and one here. Okay, so there will be two cervixes, one is here and one is here. Okay, now the classification was put forward by Buttram and Gibsons in 1979, endorsed by ASRM, that is the American System for Reproductive Medicine, in 1988. So this is the classification you need to know. Softening of the cervix, very, very simple. Goodell sign, we know that, we know all the signs. Goodell sign is softening of cervix. Palmer sign is when you're feeling with the palm, rhythmic contractions. Simple, easy to remember. Jackmers in Chadwick's is the dusky hue because of the excessive vascular congestion. So dusky hue of the cervix and the anterior vaginal wall due to congestion. Osiander sign is pulsation through the lateral fornices of the uterine artery. Piscacek sign is when asymmetrical enlargement of the uterus, because we know that the eccentric implantation of the gestational sac will grow this part more than the other part. That is Piscacek sign. Hagar's sign is again abdominal and vaginal fingers opposing each other. You do a bimanual palpation because of the softening of the lower part of the uterus. McDonald sign is easy flexibility of the uterus over cervix. Von Braun Fernald sign is softening of the fundus. So softening of the lower segment is Hagar. Fundus is von Braun. And Landin sign is softening of the mid part. So these three are softening of the upper, lower and the mid part of the uterus. Identify the forceps whenever it is after coming head of the baby. I'm not sure whether they showed you the forceps or they showed you the procedure of the after coming head of the baby. So basically the after coming head means you can see that entire baby is out till here. It is only the head stuck in. So that is not cephalic presentation, but that is breech. I heard some of them saying it was a cephalic presentation. No, when the head is inside, the baby's body is out, it was a breech. So it is the Piper forceps. Wrigley's and outlet, they are all forceps used for low cavity and outlet. So basically for cephalic presentation, Keylands is not done anymore. It is basically a rotational forceps. It has a screw. Let me show you. It has a screw here. So this is Wrigley's forceps. Oh, sorry, this is Keyland's forceps, which is done for mal-rotated, unrotated heads. Okay. So Wrigley's forceps, they have short stems and blades. They can minimize the risk of serious complication like uterine rupture. This can lead to uterine rupture. I have seen this case happening. I was working in UK. In Scotland, there was a lady who underwent Keyland forceps and she had a uterine rupture. She ended up in ICU. 16-20 bottles of blood were transfused. So this is obsolete. Still done in some countries, but we don't use it in India. Now, Wrigley's is most often used in deliveries in which the baby is far along in the birth canal. Means it is either +3 or more than +3. So this is outlet forceps, more than +3, and this is Wrigley's forceps. Kind of same. Okay, this is outlet and this is Wrigley's. Okay, so when it is not in the lower cavity, where it is actually at the outlet, then we use Wrigley's and the outlet forceps. Okay, so +2 we don't use forceps now. And even sometimes in Cesarean, as it is written here, we sometimes use it during Cesarean also. How do we do it? When the baby is kind of freely floating and we are doing a Cesarean, we are not able to get the baby out. In that case, we sometimes put a forceps, and maybe someday I will record that procedure and show it. Okay. Now, forceps are ordinary mid-cavity forceps like Gas forceps, Neville Barney. Forceps can be used for delivering the after-coming head of the breech. Why do we use Piper forceps? Because it does not have the pelvic curve. It has a reverse pelvic curve. Or you can say Piper forceps have only the perineal curve. There is no pelvic curve. See the difference. This one is a Wrigley's forceps. So if you keep it, the pelvic curve will point upwards. See the Piper's fossa. It is a opposite one. So the pelvic curve is like this. So it is a reverse pelvic curve. Okay. So no pelvic curve or reverse pelvic curve with a perineal curve is Piper forceps. Then patient came 6 months after normal delivery. I have discussed this before, with complaints of swelling and pain at the site of episiotomy, which increases during periods. The tagline here is, a tag word is increases during periods. So this is something pointing towards endometriosis. Pain while passing urine and defecation also means she has endometriosis coming there. Okay. Palpation reveals a nodular lesion. So definitely after 6 months, episiotomy is healed properly. Within 2 months, it heals. What does it actually indicate? If they have not told you that it was a nodular lesion or it is kind of worsening during periods, then you would have thought maybe inclusion cyst, because the most common vaginal cyst is inclusion cyst, followed by Gardner's cyst. But here they have told you it is a case of exacerbating symptoms during menstruation. That is definitely scar endometriosis. Episiotomy endometriosis. It is not melanoma. There is no retained suture after 6 months. Okay. And it will not give these kind of symptoms. There may be a nodule with a retained suture. There may be a suture reaction, but why it is worsening during periods? Now, sites of endometriosis, just recapitulating, abdominally, usually it is confined below the umbilicus. It is very rare to find endometriosis in the lungs, but yes, there may be hemoptysis and problems in the lungs if there is endometriosis. Extra abdominal, if it goes, it can go up to the abdominal scar for hysterectomy. So you've opened the abdomen, you've done an incision on the uterus, so it might just come out from the uterus and get implanted on the abdominal scar. Maybe some tissue while suturing you took in the needle, it went to the abdominal scar. Cesarean scar, tubal stump. So you cut the tube, so the endometrium has come there. Amputated cervical stump, so you remove the half of the uterus, means subtotal hysterectomy is done. So you've removed this part of the uterus, this much. Some endometrial tissue went here and got implanted on the amputated cervix. Then myomectomy, episiotomy scar, which is there in the question. Rarest, it is in the CNS and the spleen. Very, very rare. Spleen is said to be the only organ where endometriosis was not reported, but recently we have found some cases. So it was initially rare, but initially not seen, but now it is rare. Okay. Within the pouch of Douglas, or you can say below the umbilicus, what is the descending order of endometriosis? Most commonly ovary leads to chocolate cyst, then comes pouch of Douglas, means uterosacrus and pouch of Douglas together, leading to dyspareunia, then broad ligament, and then comes the fallopian tube. Last is the fallopian tube. Then pathogenesis, pelvic endometriosis, pelvic peritoneum can be involved, abdominal viscera can be involved. You can see endometriosis on the sigmoid colon, on the ureters. Then rectovaginal septum leading to dyspareunia, umbilicus, abdominal scar, episiotomy scar, vagina, cervix, lymph nodes can also have endometriosis. Distant, rare, but it can go up to lungs, pleura, skin, lymph nodes, nerves, and even the spleen and the CNS. Now, next question. Gravida 3 para 2 L2, 2 live children. She comes with previous 2 LSCS. So both the children were born by LSCS. She comes with a herpes lesion. So basically, it is an active herpes lesion in vagina. You will not go for normal delivery. So why will you go for a vaginal delivery? Why will you induce her? So now the confusion is classical or lower segment. Why will you do a classical in a herpes lesion? It is in the vagina. You don't have to cut the uterus upwards. Why do you have to cut the upper segment of the uterus? If it is in the herpes is in the vagina, it is not affecting the lower segment. You have to just go through the lower segment only. Okay, so the answer is lower segment. Very simple common sense question, just to confuse you. Lady got pregnant with copper T in situ, threads are visible in the vagina. If they have not given you this, the answer will be different. But threads are visible in the vagina means you have to just simply remove the IUCD gently. I would say it is incomplete question. They should have said ultrasound was done and the IUCD was seen in the cervical canal or in the lower segment of the uterus. The pregnancy was well above. The copper T or IUCD was not near the pregnancy. Then the answer would be gently remove the IUCD because she wants to continue. If she doesn't want to continue, then you can do an MTP. You can remove the IUCD along with the DNC that you are doing, or you can sometimes do an ultrasound guided removal because she's not wanting the pregnancy. You can do anything. You can do an X-ray. You can see where the IUCD is. She's wanting the pregnancy. You cannot do an X-ray. You cannot just tell her to continue pregnancy. She will end up in abortion and other complications. You have to try and remove. If you cannot remove, for example, within the uterus, the T is here and there the gestation sac is here. In that case, either she will abort herself or even if you try to remove, she will abort. So in that case, you tell her to continue the pregnancy and see what happens. Tell her this might happen. Okay. And sometimes we have seen, very rarely, I've delivered, I think, one case when I was doing my PG, that when I removed the placenta, and the back of the placenta, I could see the copper T, the T just kind of implanted, or you can say got buried inside the placental tissue. So that was basically a leftover property which was not removed. Okay, so you do not have to terminate because you're wanting the pregnancy. You have to remove the IUCD gently. So quickly, how do you manage missing threads? Rule out ectopic. First of all, sonography has to be done. It is an incomplete stem. Sonography showed that it is an intrauterine pregnancy with IUCD not near the gestation sac in the lower segment in the cervical canal. Then the answer would be gently removed. Okay. If pregnancy is unwanted, simply abort and remove the IUCD. Do an X-ray or do an ultrasound, remove it. If she wants it and you cannot see the threads, then what you do? If you are seeing the threads, that is the question, you remove it gently. You have to say it gently because sometimes you might just pull the gestation sac out. Now, if it is not visible, then you let it stay in, but you have to tell her that there's a chance of abortion, infection, bleeding, preterm labor, premature rupture of membranes, and IUGR. It will automatically generally come out with placental expulsion. As I told you, I have seen one case. If threads are visible and IUCD is lying in the cervical canal, remove it. If threads are not visible, you cannot put that probe inside. You know this hook inside. You will put a hook inside and we probe the cervical canal. Okay, I forgot the name of that hook. You should know it. We were going for the exam. So I've discussed that in my lectures. So that hook is not used when she's wanting the pregnancy. You will create bleeding. You will cause trauma to the cervix. Okay. So chances of skeletal deformities have been noticed more in pregnancy with IUCD, and that was known as the Gainer study. So this is how you will manage a patient who either wants a pregnancy or does not want a pregnancy. She wants a pregnancy, threads are visible, and the IUCD is much more away from the gestation sac. Very simple. If it is in there, you cannot see the threads, or if it is near the gestation sac, then you have to counsel. This is how you manage it. If there are two fetuses in a pregnant female, but their gestation age is 1 month apart, what is this called? So I was just laughing today, and I was discussing with my assistants today that we made a reel on this particular superfecundation because of the movie. Superfecundation, superfetation, we don't read this. You people don't just forget it, because you know superfetation is not possible in humans, because no lady will menstruate again and will ovulate again after getting pregnant. But this is a hypothetical question. Hypothetical question, and they've given you clear cut that the gap is 1 month. So 1 month means she has ovulating again in the next cycle. That is children's superfetation. That is not superfecundation. It is not the bad news wala Vicky Kaushal and Tripti Dimri. That is the reason why you got this question. Superfecundation will happen within 2 days. You know, ova can be released within 2-3 days. So either the lady has released 2 ova simultaneously, and in the same coitus, she got pregnant with her husband, with the same partner, one partner, and the dizygotic twins have happened. Or if she released the ova later, and for example, she released 2 ova today only, and she had sexual activity maybe today and again tomorrow. So today she got pregnant with her partner, with one ova got fertilized. The other day, because ova remains alive for 24 hours, she got pregnant again. That ova also got fertilized. So there will be a gap of 24 hours, but not 1 month. Okay, so that is superfetation. So superfecundation, fertilization of 2 different ova in the same cycle. So there will be a gap of not more than 2-3 days by separate acts of coitus. It can be a same partner or different partners within a short period of time. Superfetation not possible in humans, but if it is possible, it will not be after 12 to 14 weeks, because after 12 to 14 weeks, the entire uterus is full of amniotic fluid. The obliteration of the uterine cavity happens, and hypothetically, it will not happen after 12 weeks in humans. First of all, it is not possible only, but you never know. In medical science, anything can be possible. Patient might ovulate. Later on, we may get a case in the journals that, okay, there was a lady, she had a superfetation because she ovulated again after getting pregnant in the previous cycle. So anyway, the answer was superfetation, 2 ova released in different menstrual cycles. Patient with severe preeclampsia was started on magnesium sulfate. Very high yield topic. Magnesium sulfate is going to come in your INSET exam definitely, because I've gone through the last 10 papers of the last 5 years. INSET, twice a year you have it, and every paper has magnesium sulfate and preeclampsia in somewhere. What will not be done in routine monitoring? I'm not going to repeat that. You have to go through the question number 15. If you've not seen that, just see that I've told you the entire chart. What we don't monitor is routine magnesium sulfate. It is not recommended by ACOG. We do DTR, we do urine output. 30 ml per hour is the dictum. Respiratory rate should be more than 12, and they should be, and the pulse oximetry, it should be more than 96 on air. Next question, identify the grade of perineal tear in the image given below. Now, I don't know what kind of image you got, but everybody was saying it was involvement of the rectal mucosa. So I took this picture from the net. So 4th degree is basically involved with the rectal mucosa. So 1st degree is simply vaginal mucosa, that is V. This is vaginal mucosa with muscle, VM. This is vaginal mucosa with muscle with anal sphincter. Now, this can be A, B, C. What is A, B, C? A is less than 50% of the external sphincter. So we're talking about the external. More than 50% of the external sphincter is B. And C is EAS plus I, internal anal sphincter. We know the anatomy, internal and external, how they are formed. So 3A, 3B, 3C is also the definition. And here the fourth degree is VMA, that is vaginal mucosa, muscle, anal sphincter, and R, that is VMAR, that is rectal mucosa. Okay, so this is what they are showing. First degree, this is second degree, this is the episiotomy that we do. Third degree is involving some parts of the external sphincter, and here the rectal mucosa is also open. So you can simply see that perineal body. Okay, so when it is simply first degree, it is a mucosa, sometimes the skin also. Second degree is involving some muscles of the perineal body, that is the episiotomy that we are giving. So the perineal body is the obstetric perineum, that is a diamond shaped perineum that we are cutting during delivery. Third degree is some part of the anal sphincter, and fourth degree is a rectal mucosa. Okay, now let's quickly recapitulate what we actually read in the anatomy lectures. Obstetric perineum. Perineal body has 3 layers of muscles of the pelvic floor. They are represented in the perineal body. So we have superficial, deep, and the main one, the levator ani. So the 6 muscles that pass through it are the blessed, BLESSD. That is bulbospongiosus, levator ani, and the levator ani, which part is passing through the perineal body? All the pubococcygis, the ischiococcygis, and the ileococcygis. All 3 are getting inserted into the perineal body. Then external sphincter ani, superficial transverse perineum, so BLESSD, sphincter urethra and deep transverse perineum. All these blessed 6 muscles are getting inserted into the perineal body. What are the structures we are cutting in the episiotomy? So out of blessed, we are not cutting E and we are not cutting S. We are not cutting the external sphincter and we are not cutting the superficial transverse perineum. And we are not cutting the sphincter urethra. So these two, if we remove them, then it becomes BLSD. That is bulbospongiosus. L for levator ani, only the pubococcygis part, not the ischiococcygis, not the ileococcygis, because episiotomy, you know, we are going like this. This is a rectal anal sphincter, and this is the vaginal hole, and this is the urethra. So we are cutting the pubococcygis part of the levator ani. BL and S is superficial transverse perineum because it is in the pouch, the deep pouch, and the deep transverse perineum. So we're cutting through the pouches, the deep and the superficial perineal pouches. Apart from that, because we are making it a second degree tier, we are cutting the skin also. So that will be skin and subcutaneous tissue. We're cutting some nerves and vessels also, and we're getting the posterior vaginal wall. That is a mucosa also. So basically NBSS, you can either remember it this way. NB, that is blood vessels, and S is the vaginal wall and the skin. Okay, so NBSS you can just remember, or simply BLSD. Okay, muscles that are not cut are ischiocavernosus, ischiococcygis, that means the coccygis muscle, and the anal sphincter. We are not cutting that. Okay, unless we are doing a perineal tear, we end up in a perineal tear. Identify the procedure. I told you in my previous lectures also, in the MCQs also, that I have made in breech delivery, management of breech. They will only show you the diagrams, they will only show you the photographs. You need to know what this photograph is. So basically what is happening, the baby's legs are just being pulled up. So that is what, that is basically burn marshal technique. And there is another technique known as Brach technique, which is not done much. It is basically, there's a difference between Brach and burn marshal. In burn marshal, we are not we are basically letting the baby hang by its own weight. This is burn marshal. In Brach, we are not letting the baby hang by its own weight. We are holding the baby and then simply taking the baby up. So kind of similar, just not letting the baby hang by its own weight. So this is burn marshal. What is Lofset? What is Vigan Martin? What is Prague? What is Morrisolo smelly wheat? You need to know all that. Okay. So this is Lofset when you are trying to rotate the shoulders and dislodging the shoulder from beneath the pubic symphysis. This is Prague. That is when the baby is facing anteriorly, ventrally. So this basically you removed the baby till here and you're not able to turn the baby anterior-posteriorly. You're not able to turn the back. So in that case, you have to use this maneuver, Prague maneuver. Okay. This is Morrisolo smelly wheat, right? Morrisolo smelly wheat technique. And this is another one which is almost similar to this, which is Vigan Martin technique. Vigan Martin and Morrisolo smelly wheat, the difference is in Vigan Martin, you're putting a finger in the mouth of the baby and putting a jaw traction. You're not giving a shoulder traction. There is no hand on the shoulders. Here in Morrisolo smelly wheat, you take the entire baby on your hand. You're not putting any finger inside the mouth. You're just giving this traction and the other hand is giving the traction on the shoulder. So that is Vigan Martin. Oh, sorry, Morrisolo smelly wheat. Then 30-year-old lady, para 2 L2 with two live children, presents with cervical elongation. So her cervix is long. There is no prolapse. Her family is complete. She has no other symptom. What will you do? Definitely you have to amputate the cervix. She doesn't need any more children. So Fothergill will be the answer. McCall's cultoplasty is not done here. It is basically for enterocele. Lee-Ford colpoclesis is done after 60 years of age. Hysterectomy, no. She doesn't have any other symptom. Why will you go for hysterectomy in a 30-year-old female? Young woman underwent surgery for prolapse. As I told you, sacrocolpopexy means sacral promontory. It is an abdominal procedure. It is a gold standard procedure for vault prolapse, right? They haven't given you the diagnosis. They have just showed you this picture. I hope this was the kind of picture you got. So this is mesh getting stapled onto the sacral promontory. So that is sacral promontory. Okay, ischial spine is done when we do a vaginal fixation, when you go through the the sacrospinous ligament through the ischial spine. Now, uterosacral suspension and mesh surgeries. Just repeating them. Uterosacral suspension is procedure where vault is stitched with the uterosacrus after vaginal hysterectomy to prevent the vault prolapse. So this is basically prevention. Whenever I do a vaginal hysterectomy, after cutting the uterosacrus, I have removed the uterus. Before I close the vaginal mucosa, I will pull these uterosacrus down and stitch them with the vaginal mucosa so that support is given to the vaginal mucosa. Otherwise, after some years, she will come back with vault prolapse. So this is prevention. After vault prolapse has happened, we do a sacrospinous fixation vaginally, or we do a sacrocolposuspension, means we are fixing it abdominally with the sacral promontory. There is another word which is confusing, that is colposuspension. Colposuspension is nothing to do with prolapse. Colposuspension is basically you are suspending the, colpo means what? Colpo means vagina. So you are suspending the vagina. Then there is another word, colposuspension. Colposuspension and uterosacral suspension are different. You have to go with the words. Uterosacral suspension means you are attaching the uterus or the vault to the uterosacral ligament. Sacral promontory, when you are doing it, is sacrocolposuspension. You are suspending the colpo, means the vagina, with the sacral promontory. Sacrospinous fixation means you are fixing the vault of the vagina with the sacrospinous ligament. Then colposuspension means you're just simply suspending the vagina. When do we do that? You do that in stress incontinence. Whenever the patient is leaking urine, there's a problem with the uretrovesical angle. So to correct that, you do a colposuspension. You pull the vagina up and you do the lateral line attachment, the detachment of the ilio-pectineal line. That is colposuspension. So don't get confused. Mesh surgeries, synthetic or biological meshes are used. Both can be absorbable and absorbable. I told you Purandir technique, and that is the anterior technique, and the posterior one is the Shirodkar technique. Prerequisites are normal uterocervical length is required. Now, I don't know whether you got this photograph, but the question was 40-year-old woman presents with heavy menstrual bleeding, something coming out of vagina. Now, something coming out of vagina, SCD always indicates genital prolapse, right? You will think it is a prolapse case, but why is she bleeding heavily? Her childbirth was 10 years back. Bimanual palpation, uterus is palpable, means it was not the uterus coming out. They did a bimanual palpation and they could feel the uterus inside the abdomen. So that means uterus is inside. On examination, cervix admits one finger. Okay, and the following is seen. Why is the cervix admitting one finger? Because it is open. It is open because this big fibroid polyp is protruding outside the cervix. So that is something coming out. Inversion will not look like this. Inversion will look like this. Okay, so the cervix will be high up like this. So when you do a bimanual palpation, you will not feel the uterus because the uterus has come down. It has kind of started inverting like this. So what will you see later? It will be like this. It will be like inside out, as if you have turned the gloves inside out, or you have turned your socks inside out. So this is how it will feel. You cannot feel the cervix with the one finger. You cannot feel a bimanual palpation uterus. So inversion, no. Intramural fibroid, why will it prolapse outside? It will be inside the wall of the uterus. Intramural fibroid will be inside the wall of the uterus like this. Fibroid polyp, yes, it can be cervical fibroid. It can be coming from the uterus and hanging down. Adenomyoma will not look like this. It is definitely fibroid polyp because that is why it is bleeding horrendously. 32-year-old gravid 2 is diagnosed to have DVT at 30 weeks. Now again, we have discussed this. The drug of choice at 30 weeks is warfarin. It is not low molecular heparin. Low molecular heparin is given in after 36 weeks because it has less potency, and that is why it is preferred during delivery time. But during pregnancy, from 12 till 36 weeks, it is warfarin. Because it is a very potent drug, even though if it can cross placenta, it is not going to harm the baby if it is stopped at 36 weeks. Okay, so I'm just explaining these two drugs, which are kind of jargon for me also. So I don't know what is fondaparinux and apixaban. So I just Googled and I got the answer for you, just in case this question gets repeated in INSL. So fondaparinux, the trade name is accreta. It is an anticoagulant medication. Maybe you must have been taught in medicine about this drug. It is chemically related to low molecular weight heparin, marketed as Viatris. Okay. Apixaban is again an oral anticoagulation. It is oral, it is not parenteral. Approved by US FDA in 2012. It is used for non-valvular atrial fibrillation to reduce the risk of stroke and blood loss. So this is oral, and this is analog of low molecular weight heparin, so again parenteral. So I just googled these two drugs. I don't know why they gave you. So remember, for anticoagulation, it is heparin and it is warfarin for us, unfractionated or low molecular weight. I told you the difference. Then, coming to the end of the lecture now. 45-year-old woman with a history of cervical erosion and spotting since 2 months. What is the next best step? Now, cervical erosion and spotting you are getting in a 45-year-old. She's high risk for HPV. After 40, you know, HPV can integrate and cause CIN. It can cause HSIL, high-grade lesions. So you will go for LBC, you go for HPV also, and you go for cervical biopsy if you can see the lesion. The other options are not matching. I don't know what the other options were. Why will you do a HCV or ECV? Why will you do it? HCV is hepatitis C virus. Why not HPV? It is not HCV. And why will do a hepatitis B virus? So nothing is matching. It is only this. Okay. So it is very important to go through the guidelines of CIN management. 28-year-old G5L4. So she has 4 live children, 4 girl child. Presents at 18 weeks. Ask for the sex of the child on the ultrasound. Will you do a sex determination? It is absolutely banned. Your FMT classes, Dr. Aditya will tell you, it is absolutely banned. This is her first antenatal visit. Do an ultrasound for gestational age. Check for abnormalities because she's at 18 weeks. Check her sex and tell the mother, no, not at all. Do ultrasound, check abnormalities, check sex, but don't tell the mother. Okay. Do ultrasound, just check for abnormality, don't check sex. I think that is the best answer. Why will you check the sex? You don't have to check the sex. Don't do ultrasound, do ANC only. No. You have to do the ultrasound, do check for abnormalities, do not check for the sex. You don't have to. Unless you feel that, okay, in the stem, there is given that the girl child died or there was some sex-related problems, sex-related metabolic diseases or some chromosomal abnormalities. Then you go for check for the sex of the baby, the gender determination. Otherwise, you will not do it. So that is it, guys. Thank you for listening to me and all the best. And I'm sure there's an overlap between NEET and AIMS. The way they have projected the questions this time, integrated questions, more of image-based questions. Don't get confused. Keep your mind open, brains open. You've read everything. सब कुछ आता है मुझे. इस confidence से जाओ. डरो मत. सब हो जाएगा. Okay? I'll see you in the INSF paper. Thank you. Bye-bye.